Okay, good afternoon, everyone. In behalf of the ASPA Pediatric Pain Special Interest Group, I welcome you to the pre-third annual general meeting lecture or talk by our advisor, Dr. Alan Finley. Next slide, please. Okay, so just some housekeeping. Some of you may have questions, and we encourage asking questions and these questions to be shared via the Q&A section. The chat and raise hand functions are disabled for the length of the talk. Our moderators will highlight your questions to the speaker, to Dr. Finlay after the talk. And it depends if some of the questions that you have posted can be answered during the talk itself as well. All right, this talk, in case you miss it online or live today, it will be uploaded in the ASPA YouTube. And yeah, we also have some materials in the Pediatric Pain Special Interest Group in our Facebook page. Okay, all right. Sorry, I don't think I introduced myself. I'm Dr. Catherina Epino. I'm the incoming lead for the Pediatric Pain Special Interest Group of ASPA. And this afternoon, I have the pleasure of introducing our guest speaker and our advisor as well, who I have met in Nova Scotia as well. Dr. Alan Finlay is a pediatric anesthesiologist, a professor of anesthesia, pain management, and perioperative medicine at Dalhousie University. He holds the inaugural Dr. Stuart Wenning Chair in Pediatric Pain Management at IWK Health in Halifax, and is the director of the Center for Pediatric Pain Research in the same institution. He started the pediatric pain email discussion list in 1993. I remember on this list, Dr. Finlay, when I was a fellow still, and I really appreciated the discussions there. His main interest, his passion for pediatric pain has taken him all over the world. His main interest is pain service development, very lucky for us, and advocacy for improved pain care for children worldwide. He is also a co-founder and a board member of the Childkind International Initiative. So without further ado, thank you very much again, Dr. Alan Finlay, for gracing our pre-AGM meeting or in giving us this talk. I give the floor to you.
Thank you so much. It's a real pleasure to be here with you all, virtually at least. I'm just going to share my screen and set up the talk. All right, so I've been asked to talk about partnerships in pain management and why we need them. As you all know, children have many causes of pain while they're in hospital. Pain due to injury, surgery, burns, diseases like cancer and infections, meningitis, other widespread conditions. The worst pain from a children's point of view is often the tests and treatments that we cause them. So these are pains that we give them, which is particularly difficult because we're supposed to be helping them. People usually divide pain into acute and chronic, but I kind of split it up into the acute into two different sections. One is the incident pain, which is procedures like IV catheters and biopsies and so forth. The immediate post-operative or trauma pain, that's when the surgeon comes, examines your abdomen just after your laparotomy and pushes on it. And then there's the continuing and persisting pain, which can go on for prolonged periods, even without movement, or is disease-related. Chronic pain, as you're all aware, is a complex biological and psychological and social issue, but that's not really what we're talking about today, because we're looking at the acute pain service in the hospital, which is generally run by anesthesiologists. Now, we're all very smart. We know all sorts of stuff, so we don't need anybody else, right? Our goals in postoperative pain care are fairly widespread. By the way, let me ask you, someone to let me know if I'm speaking too quickly. So our goals of postoperative pain care are to reduce suffering, to facilitate recovery. So we're trying to allow active movement without splinting, without restrictions. We want to decrease the catecholamine release. We want to manage the side effects of medications and of the treatments. We want to shorten their hospital stay and develop self-efficacy for home so that they're able to understand what hurts and why it hurts and problem solve, thereby reducing the risk of readmissions for pain, which add to costs and difficulties for the family and cost to the healthcare system. And part of all that is enhancing their trust in us, in the healthcare professionals and in the healthcare system. Why do we need partners? Because we can't be there all the time. And guess what? We don't know everything. This is really important to understand. There are all sorts of things that the nurses I work with know that they learned in nursing school that they never taught me in anesthesia school. So we need partners in nursing, in surgery. We need other healthcare professionals. And above all, we need families to be partners with us in helping their children. So how do we work with surgeons? We need this collegial collaboration with them. We have to understand their goals. Do they want the child to move, to be active early, to get out of bed? Or do they want them to stay quiet and calm to prevent strain on a tenuous surgical repair? How is their diet progressing? Are they allowed to eat or not? Many hospitals have started developing ERAS, early recovery after surgery protocols. These protocols and care paths need to be developed together with the surgeons. So surgery, nursing, and anesthesia need to come together to develop these protocols, because otherwise they just won't be followed. As you probably know, these include things like fluids and carbohydrate loads before surgery, early resumption of eating, no use of NG tubes, and pain management protocols. And then we have to ensure agreement with the surgeons about what we're attempting to do. For example, some orthopedic surgeons are uncomfortable with anti-inflammatory drugs after certain types of surgery. There's no point in fighting about that because that just interferes with patient care. So if I'm writing an order for postoperative ketorolac, I'll usually add to the order to say if surgery agrees, just to ensure that they feel included and that everybody is on the same page. Now, this Norlink comes on in a nice little sequence. However, let's talk about pain assessment. Have a tissue trauma, which might be an injury or surgery. In a child, this creates a pain experience which is affected by their own biology and their personal history and the social and physical context. Fracture winning the tournament football game is different from a fracture after treatment for cancer, which might indicate a recurrence. Then they have to express their pain, either preferably by self-report or by behavior or physiological change, and that's affected by their motor abilities and the social display roles, what they feel they can do or say. This creates the opportunity for the professional or caregiver to assess the pain, which depends on their own knowledge and attitudes and their relationship to the child, and then to do something about it, either pharmacological, cognitive, behavioral, or environmental, physical. That depends on the institutional policies and barriers as to what they're able to do. And then that feeds back to the pain experience. Pain assessment occurs right here and is really more complicated than you might think. So who can assess the pain? It turns out that nurses assess pain better than we do, better than physicians. Parents assess pain better than the nurses do. And really, this must depend on the personal experience with the individual child, not experience with children in general. Every child is different. Parents' global scores have been shown to correlate more closely with self-report than do the nurses or doctors. But nevertheless, self-report by the child depends on their trust with the person they're talking to. And children have lots of reasons for not telling you about their pain. They might be afraid you're going to get a painful treatment, a needle, or that you're going to come and examine them and hurt them more. They want to be good. They want to go home and are afraid that this might interfere. They don't want to worry their parents, or they might worry that something really must be wrong. In Thailand, people talk about khang jai, a desire not to upset their older or senior associates. So how do you build an assessment team? How do you develop those skills? So the best approach, I think, if you can do it, is to have an advanced practice nurse, a clinical nurse specialist or nurse practitioner, or at least a full-time nurse clinician who's part of the pain team. She can do pre-op patient assessments and teaching, and rounds on all the patients once or twice a day, guiding drug titration and weaning, assessing pain control and the side effects, and collaborating with the surgeons. She teaches unit nurses and families and reinforces the importance of pain function as well as pain intensity. And so this is who keeps you informed while you're in the operating theater. And our center checks in several times a day, lets us know what's going on, because we're tied up and can't leave to go and see the patient personally. So that's a great approach if you can arrange it. However, if you don't have that, you need to educate and support pain champions on each unit. A nurse who maybe gets some special training and special opportunities to learn. We call these nurse facilitators or nurse fa in the study we did in Isan in northeastern Thailand at Khon Kaen University. Most important, and this, I can't emphasize this too much, you need to develop relationships and trust with the unit nurses. Even if you have an advanced practice nurse during the daytime, you need somebody on nights and weekends who you can rely on to give you a report about a patient, to let you know if there's a problem, if pain's not being managed. We need to treat them as colleagues and respect their skills and knowledge. And most important, as I think probably most of you know, don't yell at them when they call you at night. As hard as that sometimes is to avoid. If you give them the trust and they know that they can call you if they are concerned, then you can relax and know that if you're not called, everything is going fine. If the nurse is afraid to call you, then you have to worry that something is being missed because she's afraid to disturb you. Very important in making your life better. Parents are the experts in their own children. Now, they recognize when behavior isn't normal, although they don't always understand the reason for that change. Some may be afraid to report pain in their child because they don't want to look like they're complaining. They worry that that might affect the care the child gets. So they have to understand that you trust them. You ask their opinion, you explain your goals and plans so that they know what's going on and that your goals are the same as theirs, which is to keep their children comfortable. We still need other skills. After surgery or trauma, failure to move prolongs the recovery time. You get short and long-term reduced function or disability and usually increased pain. Physiotherapists are the experts on movement. They can assess abilities and barriers and functions. They can teach patients how to move without pain, or at least with less pain. And they're skilled at motivation and dealing with the fear of movement. Psychologists are the experts at assessing and treating anxiety, teaching self-management skills, teaching parents techniques to support their children, motivating for recovery, preparing patients for body image changes. Surgeries like scoliosis repair, pectus repair, cleft lip surgery, particularly if it's done at an older age, or other types of plastic surgery and burn reconstruction, all change the body image. And this can be traumatic for children when they look in the mirror and see something completely different. Now, ideally, much of this preparation would happen before surgery, but having those resources available after the operation are extremely valuable. I'll just show you quickly this very complicated diagram from work by Joel Katz from Toronto from quite a few years ago. But these are the interactions involved in the transition from acute pain into chronic pain. And we all know how important it is to prevent that transition. And I've just circled 3 areas there that are particularly relevant to psychological intervention and why psychologists are so important in this process of managing acute pain. So ideally, you would have all these people available. You'd have a pain team that included both the anesthesiologist and the surgeon. You'd have an advanced practice nurse, a physiotherapist, a psychologist, maybe an occupational therapist and social worker as well, and the parents. It's pretty rare to get all these people together. We have physiotherapy, psychology, advanced practice nurse and physician on our complex pain team in the chronic pain clinic, but we can't get all those together at the same time for acute care, for post-operative care. There is a physiotherapist who sees all the patients, and we work with them, but psychology coverage is less frequent, and we may not see the surgeon at all when we're doing our rounds. However, you need to put together the resources you have, advocate for more support, because in the long run, it saves money for the hospital to do this properly. And collaborate. If you do this, you'll have more fun, you'll sleep better, and you'll help more patients. Thank you very much. So that's a brief view of of some of these issues, which is, I think, what I was asked for, I hope.
Yes, thank you. Thank you very much, Ellen. So we just like to ask the participants to please feel free to put your questions in the Q&A, and Prof. Ellen would be very, very glad to answer them. He's a huge proponent of setting up pain services and having and advocating for good pediatric pain management in particularly the Asian region. He has a soft spot for us, I think, which is why he woke up at 4 in the morning to do this for us. Thank you very much, Alan. Could I just ask you, while we're waiting for people to kind of put up questions, I understand that you did some work in Thailand, is that right? With, I think, your team Sahatsa, is that correct?
It was actually out of Khon Kaen University with Ajahn Sambon Tientong and Womenrat. And I think Womenrat has been part of this group at times.
Womenrat, yes.
Sambon is retired, but we worked through 7 hospitals in northeastern Thailand and developed. We had this wonderful group of nurse facilitators, Nurse Fa, who were very enthusiastic. They got extra teaching and some travel opportunities to Khon Kaen for workshops. And then they went back to their hospitals and developed resources and came up with ideas that I wouldn't have thought of. You know, if you're 2 nurses on a night shift and you've got 40 patients on the unit, which was the situation in some of, in the regional hospitals, the smaller hospitals, it's hard to keep track of everything. So they were using, in this one hospital, they were using paper charts, and they put a large red P on the end of the chart, letter P, on the end of the chart, so that then when they looked at the chart rack, they would remember which patients needed to be evaluated for pain, which patients had pain issues. Very simple and very practical from their point of view. I was overwhelmed, actually. The nurse facilitators got a small supplement of money for doing the extra work. And in one hospital, at least one hospital, the nurses took that extra money, and instead of taking it home, they used it to buy toys for the playroom in the hospital, which was really, just amazed me. But seeing their enthusiasm, their desire to make things better for their patients was really inspiring. And nurses, if given the chance, then they'll go for that. And in my own hospital, we have more nursing resources, obviously, although I've never ever visited a hospital that said they had enough nurses anywhere in the world. But that relationship, the nurses on the unit know that if I call them to ask about a patient, I am trusting their opinion, their assessment. And if there's a patient that I might be concerned about and I call them in the evening before I go to bed and say, how's so-and-so doing? They appreciate the fact that I've called. They're not irritated by it. So, and they know that they can call me without me yelling at them, which again, I think is hugely valuable, and promotes that relationship. I see a question there about pre-op teaching. So in our center, patients scheduled for, that we know ahead of time are scheduled for major surgery like scoliosis repair or a pectus repair. We know they're going to have a PCA pump, or patients who we know are going to have an epidural or nerve block. Our clinical nurse specialist will see the patient before surgery, sometimes the week before when they come for a pre-op visit with the surgeons and others, and show them the PCA pump, explain how it works, explain how they use the button, and give them reassurances and answer questions about pain. That is really valuable because obviously post-operative pain is something that patients are anxious about, they're afraid of. At least if they're smart, they are. And so that reassurance is really helpful for them. I would love it if we had a clinical psychologist available to see all these major surgery patients ahead of time as well. But again, we don't have that availability. We have psychologists available by consult for patients who are showing problems, but because that's not feasible for everybody. I'm looking at the other questions here as well. Ayuko agrees with me and says that working with the unit nurse is okay, but sometimes difficult with surgeons. And yes, it can be difficult with surgeons. All I can say is it takes time, it takes diplomacy. I've said for years the most difficult, that pharmacology is easy, politics is hard, and developing those relationships are hard. Years ago, I said that the pain management in orthopedics would be solved eventually because the head of orthopedics was older than me and he'd retire first, and that's what happened. And now we have 4 orthopedic surgeons who are great and happy to have us involved and collaborate with us. So we got together with the 2 spine surgeons and the acute pain physicians and nurses and pharmacists and worked out a care path and a protocol for scoliosis surgery so that the straightforward idiopathic ones that weren't complicated would go through a more rapid evolution from PCA to oral medication and would end up being discharged much more quickly. But that had to be done collaboratively. And all I can say is keep trying, work with them, try to avoid fighting with them, establish policies and protocols that they have to go along with. In the early years, we had some surgeons who felt that they knew that they can discontinue the PCA, when really we knew that it actually needed to be turned up, turned off, and we had to go through those processes, but it can be difficult.
Thanks for that.
Training the team.
Yeah.
Sorry?
Sorry. So yeah, I was going to help you quickly screen through the questions.
Yeah.
You were talking about the ideal team. So the 2 questions that we have are about training that team and whether, like, how you would train them, and whether they train together and separately. And I think the other question is about chronic postoperative pain, and I think the transitional pain in essence, and what needs to be monitored, or whether it should be monitored more closely after specific surgeries in your experience.
Yeah, I can see the questions here too. So basically, we don't have that ideal team. So the physiotherapists who are on the unit understand pain, understand what we do, understand our approach. and are great at coming to us and saying, look, I'm worried about so-and-so, he's not moving well, or so-and-so needs, has a lung down and needs to breathe better, and what can we do to help his pain so he can do that? So that when I talk about a team, really it's the clinical nurse specialist and the physician. We currently have 5 physicians doing acute pain. So we do a week at a time, 24 hours. So we do rounds in the hospital at least once a day, and then we take calls from home, which, because we know the patients, because we're on for the whole week, we can usually answer most of those calls by telephone without having to come in, which is an advantage over more frequent turnover. And the clinical nurse specialists are outstanding. As I said, we don't have really what I would like to have in terms of psychology support pre-op or post-op on the nursing units. Post-operative, so chronic pain is a recognized issue after some types of surgery. Unlike some places, we don't have a formal transitional pain service because we're not that big. And we have a crossover, the same nurses do acute and chronic pain. 3 of the 5 physicians who do acute pain also do chronic pain. And, we deal with 4 orthopedic surgeons and 4 general surgeons. So we pretty much can keep in touch and talk to people if there's someone we're worried about. If you've got a much larger service, then there probably is value in having a more formal transitional pain program. There are certainly patients we see on the acute service that we then say this patient also needs to come to the chronic pain clinic, and please make a referral there. And then we follow them with the chronic team. Scales used to define chronic postoperative pain. I don't know of any specific scale, and we don't use anything formalized. What you're always looking for is pain and function. And when we see kids in the chronic pain clinic, when they come back for a recheck appointment and they say their pain is the same, but they're doing more activities, we're able to show to them that that's an improvement because their function's better. Function improves before pain improves. In the acute pain setting, that's a little different, but perhaps not that different in that if you have spine surgery and it hurts when you sit up in the edge of the bed, it gets better when you lie down, then the next day it hurts the same when you get up and walk to the bathroom, then that's an improvement in that you're doing more even though the pain is the same. And that's education of the patient and the family and helping them understand that we're never going to get 100% relief of the pain, but we're controlling it. It's brief, it's transient, and we're getting them back to bed, and then the pain settles down. In terms, pain after scoliosis surgery to some degree goes on for months and eventually settles down. There are some patients we see in the chronic pain clinic preoperatively, which is great, because they have pain related to the scoliosis that's been there maybe for years. And then there are others that we follow up afterwards and help them understand the progression and resolution. And we use medications like gabapentin and pregabalin and amitriptyline to help with the the nociplastic and neuropathic components. And there's a better understanding of how to use and how not to use opioids in our amongst the surgeons, and multimodal treatment to try and reduce chronic pain development. I don't know if that answers the question adequately, but
Thank you very much, Alan, for those answers. Can I just ask the audience, will there be any further questions for Prof. Alan? In the interest of time, we're at 5:20. We're going to segue into the AGM. If there are any more questions, please feel free to email us as well at aspappsig@gmail.com. And we will direct the questions to Prof. Alan.